Last thing we need to recognize about brainstem functional anatomy before we talk about brainstem vascular cases is where are and what are the neural centers that are involved in voluntary conjugate horizontal gaze. So when we talked about the vestibular labyrinth and the vestibular ocular reflex, that was a reflex horizontal conjugate eye movement in response to head turning. But now we're dealing with where are and what are the voluntary centers that allow us to move both eyes in a conjugate fashion in the horizontal plane to locate or identify an object of interest. So in our little model here, we're going to illustrate the neural mechanisms that permit horizontal conjugate gaze to the right. So in order to do that, we're going to have to wire up a neural mechanism that allows us to abduct the right eye and simultaneously adduct the left eye in a conjugate fashion. And the first gaze center that gets activated in this process when I want to look to the right voluntarily is a cortical gaze center in the left frontal eye field. So this is a contralateral phenomenon, meaning that if I stimulate frontal eye field neurons in the left cortex, both eyes will generate a saccade, a voluntary conjugate horizontal gaze in the opposite direction to the right. But the interesting feature about this is the cortical gaze center is not connected directly to cranial nerves 3 and 6 on the appropriate side. Instead, as indicated by the diagram, the axons coming out of the left frontal eye field descend down into the brainstem. They all cross the midline, and instead of going to cranial nerves 3 and 6, all of these cortical axons synapse in a second gaze control center that's located in the pons. And this pons gaze center has a terrible name in clinical neurology because its name doesn't give you any clue about what its function is or more than a general location of where it is. The name of this second gaze generating center is known as the PPRF, or Paramedian Pontine Reticular Formation. My point being that other than telling you that it's somewhere in the pons, it gives you no indication of where it is. Where it is, it's actually situated immediately adjacent to, or some consider to actually be in, the abducens nucleus. And you can see that the abducens nucleus in our diagram is situated right close by. So recall that basically these two populations of neurons are really almost in the same area. So it makes it kind of convenient because this Pontine gaze center is on the right, and basically one of the neurons that has to be activated to gaze to the right are neurons in the right abducens nucleus. So a very short neuron simply has to leave the PPRF, go into the right abducens, activate the right abducens nerve so we can abduct the right eye. So we're halfway home. But now we have a little problem. The PPRF has to send an axon out of the pons that has to cross the midline of the brainstem and has to race all the way up into the opposite midbrain to synapse on ocular motor neurons in the ocular motor nucleus so we can simultaneously adduct the left eye. And this process is enabled by the fact that there is a high-speed, heavily myelinated fiber bundle that we've seen previously in the VOR known as the medial longitudinal fasciculus. So it's the job of the MLF to send axons out of either the abducens nucleus and or the Pontine gaze center. Since they're one and the same, the axons cross immediately in the vicinity of their cell bodies, and then they race up near the midline and through the length of the contralateral brainstem to reach the oculomotor neurons on the left side so we can simultaneously adduct the left eye when we are abducting the right eye. So shown in the blue numerals are 4 lesion sites that can affect, obviously, horizontal gaze voluntarily of one or of both eyes. And fundamentally, they're diagrammed pictorially beginning on the next page. At the top of the page is, under normal circumstances, what would happen if you asked a patient to follow a stimulus that caused a voluntary horizontal gaze to the right. So as indicated by the picture on the top of the slide, we would abduct the right eye and simultaneously adduct the left eye, assuming that both gaze centers are functioning and intact, and the MLF basically is allowed to adduct the eye on a corresponding side. So, looking down at number one is a lesion of the right abducens nerve. And we talked about this in terms of cranial nerve anatomy. So certainly if you have a right abducens nerve lesion, the right eye cannot look right. In other words, you will be unable to completely abduct the right eye. So the question comes up, obviously you can normally adduct the left eye because the gaze centers are intact, the oculomotor nucleus is intact, as is the MLF. But why is the picture illustrating an eye on the right side that can at least be abducted to the midpoint? And the answer is one of the accessory functions of both the inferior oblique and the superior oblique. They act as weak abductors of the eye, but without the lateral rectus, the right eye cannot be fully abducted on the corresponding side of the lesion. And as we know, at rest, this patient is going to have an internal strabismus. The picture at the bottom of the page is an attempt at gazing to the right by a patient that has a lesion not in the abducens nerve, but a lesion in the abducens nucleus. And since the abducens nucleus really is co-localized with the Pontine gaze center, the PPRF, in this case, neither eye can look to the right, because this is not just an abducens nerve lesion, this is an abducens nucleus lesion that includes the Pontine gaze center. So obviously you can see the differences here between a right abducens nerve lesion and the right abducens nucleus lesion. Because the abducens nucleus contains the Pontine gaze center, neither eye can look to the right. But in addition, remember that the facial nerve on the right is hooking over the right abducens nucleus. So the patient that has a right abducens nucleus lesion is also going to have complete right side facial paralysis, analogous to a patient that has Bell's palsy, because of the proximity of the internal genu of the facial nerve to the right abducens nucleus. Then here's the point that we just made, where in summary, if we lesion the right abducens nerve, the right eye cannot look right, cannot abduct that eye. But when I have a lesion of the right PPRF, that's a lesion in a patient that has not just an abducens nerve lesion, that's an abducens nucleus lesion, which is the same thing as saying a right PPRF lesion. And as we pointed out a slide ago, in this case, neither eye can look right, and the patient is likely to have complete right side facial paralysis because of the proximity of the right facial nerve. So let's look ahead at the next two lesions, then we'll come back and explain them again. So in this lesion, number 3 and number 4, this is really the one to remember, because of all of these 4 lesions, probably the most common one is a lesion that involves the fibers of one or both of the axon bundles in the MLF. And recognize that the MLF, as we said, is a high-speed, heavily myelinated fiber bundle that basically allows you to adduct an eye during gaze. So, as predicted, when you have a unilateral MLF lesion, the patient will not be able to adduct an eye on a corresponding side during attempted gaze, basically in one direction or the other. And this is a very common lesion because the axons of the MLF are a very common site of demyelination in a patient that has multiple sclerosis because of the heavy degree of myelination of those axons. But one of the questions that might come up is, let's say a patient walks into your office and has diplopia on horizontal gaze, and you note that when they attempt to follow a stimulus horizontally that they cannot adduct an eye. What would give you an indication that the patient doesn't have an oculomotor nerve lesion that can be distinguished from an MLF lesion? The answer is, if a patient has an MLF lesion, they cannot adduct an eye during attempted gaze, but they can still adduct both eyes during the accommodation convergence reaction because the near response does not need the MLF to function properly. And in addition, as you see in this particular picture, if I had a third nerve lesion on the left side, in addition to not being able to adduct an eye on that side, the patient would also obviously have a dilated pupil anatosis, 2 signs that are not seen in this individual patient. Lastly, what are we going to see in a patient that has a left frontal eye field lesion? Again, this is a gaze center problem. So again, if I have a left frontal eye field lesion, neither eye can look right. There may be some drifting in the opposite direction. But you may also see a certain degree of facial muscle weakness. So in this case, neither eye can look right, but because of the proximity of the frontal eye field to the cortical bulbar fibers, that this patient might have some just right lower face weakness, not complete face weakness, as we saw in the lesion of the abducens nucleus. So skipping back now, we can kind of summarize these last two cases using this slide, where we had an example of a lesion of the left MLF. And classically, that causes an inability to adduct an eye during voluntary conjugate horizontal gaze, but convergence is intact, allowing us to distinguish a patient with an MLF lesion from one with an oculomotor lesion. And we might have a nystagmus of the normal eye because the cortex basically is pulling the right eye back in line with the eye that cannot be adducted. And recognize that the MLF is very commonly lesion, seen frequently in patients with multiple sclerosis. And note that when we have an MLF lesion that classically is described as internuclear ophthalmoplegia, it's internuclear because you've lost the link between the abducens nucleus on one side and the oculomotor nucleus on the other, hence the term internuclear. And then finally, as we indicated, lesion number 4 was a lesion to the left frontal eye field where, again, neither eye can look right. Well, one of the ways you can distinguish a left frontal eye field from a right PPRF lesion will be the extent of facial muscle weakness. If I lesion the right PPRF, in essence, I've lesioned the abducens nucleus and all of the motor fibers of the right facial nerve, so I have a complete right side facial muscle weakness. Whereas if I lesion the left frontal eye field, because of its proximity to the corticobulbar neurons, I'm likely to have just some right lower face weakness because of the corticobulbar issue and the differential innervation of facial nerve lower motor neurons. And then last point that's made on here, which we've seen with regard to lesions, is a reminder again that be sensitive about the difference between a lesion of the abducens nucleus versus a lesion of the abducens nerve. So, because as we say at the top of the page, the abducens nucleus is coexistent with the PPRF, meaning that if I have a lesion of the abducens nucleus, neither eye can look to the side of the lesion, where if I lesion just an abducens nerve, then I'm just going to have an abduction weakness on a corresponding side of the lesion. And again, if I lesion that abducens nucleus, I'm also going to have a complete ipsilateral facial paralysis because, as we say here, the facial nerve fibers are looping over the abducens nucleus.